Greetings from Professor S.K. Rajkumar, Research Scholar of Madhav University, Sirohi, Pindwara, Rajasthan. I thank INTI International University for providing this wonderful opportunity to present my topic in this, the Global Advance in Health and Life Sciences Conference 2025. My topic is effectiveness of early mid-range functional training for upper limb functions in improving upper limb function and quality of life among patients with acute stroke. So coming to the introduction, we know that stroke is a second leading cause of death worldwide, and parallelly it is a major cause of disability also. If the patient survived, so it will be with the disability. So what is the reason behind this disability is the muscle synergies are altered after stroke. That is an important thing, causing dysfunctional execution of the voluntary movements because of the corticospinal tract get damaged. Okay, and other descending pathways are also upregulated to compensate for the movements. It results in abnormal synergy of movement, which results in plasticity along with the neuronal axis. So these are all the problems behind the stroke patients, stroke survivors. So that there are 4 synergy coordination patterns, which includes merging, that is equilibrium, disequilibrium, sharing, losing, and preservations were found by the research studies. So the abnormal synergies are sign of persistent neurological deficits. So results in loss of independent joint control. So if the independent joint control is lost, what happens, which disturbs the kinetics of the voluntary movements. So this is the problem which exists in the stroke patients. So my study, what is the aim of my study? My study is application of yearly mid-range functional training for the upper limb to improve the upper limb function and quality. Okay, fine. So epidemiology, coming to the epidemiology, stroke is one of the leading cause of disability globally, estimated to be around 13.7 million individuals every year. See, when the global stroke fact sheet released in 2022 reveals that lifetime of developing a stroke has increased by 50% over the last 70 years. And at present, 1 in 4 people are at the risk of getting stroke in their lifetime. See, so that prevalence is around approximately 1% in female and 2.3% in males. Right. So background of the study. So my study background is early studies shows that abnormal synergies are sign of persistent neurological deficits and results in loss of independent joint control, and parallelly which disturbs the kinetics of voluntary movements. So before initiating rehabilitation, conducting a thorough assessment to determine the stroke is very, very important. So to achieve this, there are several instruments to use to assess the functional state of the stroke survivors. The DASH, upper extremity scale, is widely used quantitative evaluation to measure the functionality of the upper limb and motor recovery after post-stroke. See, in the post-stroke rehabilitation, main aim is improve functionality of the patients and to manage the pain, to regain the maximum possibility of the function of the affected arm. So that is our main aim, right? So the post-stroke rehabilitation period should commence as early as possible. So the functionality recovery predominantly occurring in the first week itself. Although there are studies indicating that the patients go through a phase of spontaneous recovery during the initial weeks, right? But we have to start the exercise in the first week itself. Sling exercise therapy is a liable method for training muscles. Why we are going for sling exercise therapy? for the elimination of gravity. So sling exercise therapy in a liable method training exclusively, that too in the mid-range, to enable their muscle activity in a gravity compensated position. Fine, need of the study. So need for the study is to find out the effectiveness of early mid-range functional training. Effectiveness of early mid-range functional training for upper limb in improving upper limb function and quality of life among patients with acute stroke. The aim of the study is to find out the effectiveness of early mid-range functional training. See, my hypothesis null as well as the alternate hypothesis. So null, there is no statistical difference in the abnormal synergy pattern. Alternate hypothesis, there is a statistical difference in the abnormal synergic pattern of the upper limb. After application of early mid-range functional activities in improving upper limb function and quality of life among patients with acute stroke. So these are all my reviews. Around more than 20 reviews are there. I have enlightened only 6 reviews in this thing. My methodology. So I assessed for eligibility of around 30 patients. Out of 30 patients, I randomized to 23 and allocated 15 for my study. So materials and methodology, research design, experimental study design with a pre-test and post-test evaluation. My population, both genders are selected for this study. Sample size is 15. So why I have taken only 15? Minimal sample is taken to collect sufficient data to provide the valuable information and to attain the expected outcome of the research study. Then sampling technique is consecutive sampling technique. Study setting. The study will be conducted at the Physical Medicine Rehabilitation Department of Physiotherapy of Swami Vivekananda Medical College Hospital and Research Institute, Tiruchengodu, Namakkal, which is a 1000-bedded hospital, and Vivekananda Medical Care Hospital located at Tiruchengodu, around 306-bed hospital. My study duration is 6 months. Treatment duration is 8 weeks. Parameters which I used is DASH score, that is disability of arm, shoulder and hand, and SSQOL, stroke specific quality of life. So inclusion criteria, I have included acute stroke patients, only acute stroke patients, both male as well as the female gender, and both infarct as well as the ischemic patients I have taken. Patients with manual muscle testing grading 0 to 2 I have selected. Exclusion criteria, I have not taken chronic cases. Any other pathology other than stroke I have not taken. Then if the patient is having cognitive dysfunction, it was not included in my study. And manual muscle testing grading above 2 I have not taken. Fine, procedure. It is an experimental study with a pre-test, post-test model. All the subjects are clearly explained in detail about the study. Procedure, training, protocol, merits, demerits of the techniques were also clearly explained, and the selected participants were asked to present at the date and the time perfectly. And the 15 patients clinically identified with the stroke and selected based on the inclusivity. So techniques of intervention, positioning, patient positioning, preferably side laying. So eliminated gravity for shoulder flexion movement, and patient is comfort is ensured. Therapist position, walk standing position. So principles of exercise intervention. So frequency 6 days in a week, twice a day. Intensity is muscle activation based. My exercise muscle activation. We have to actively we have to stimulate the patient to participate actively. That is an important thing. And type early mid-range functional exercises parallel to the gravity and suspension therapy. Duration 45 minutes per session. Targeted movements. I have targeted shoulder flexion as well as the shoulder abduction. So place the patient shoulder in the mid-range, tap the shoulder flexor muscles. Tap the shoulder flexor muscle so that the patient aware about which muscle to be activated. And ask the patient to concentrate the shoulder flexion. If any, for example, if any flexor of movement, the patient should recognize it. Patient should sense it. Okay, so initially we will get a response in a mid-range. Okay, maybe a 5 degrees or 3 degrees of movement. And after that, day by day, the first week we will get 5 degrees of movement. Second week we will get 7 to 10 degrees of movement. So that the progression of the movement, active participation from mid-range to the outer ranges. That is an important thing. So if this activity done with the help of mirror, which will the patient with the help of feedback, the patient can do better. And then, so this is my data analysis, pre-test, post-test score of dash. So that pre-test mean is 50 and post-test is 10.8. And then SSQOL mean is 129 pre-test and post-test is 352. And then see the graphical representation, it's clearly noticed that so the patient quality, SSQOL quality is improved, and parallelly the dash, the disability is reduced. So graphical representation, it's giving a clear picture regarding the study. So this is my video, pre-test video. The patient is a left hemiplegic. Patient is a left hemiplegic. He could not able to lift during that initial period. So this is the pre-test video. Patient could not able to move the limb. The patient name is Rajagopal. So I have initiated the mid-range activation. Actually, this is not an eliminated gravity position, but even though, and this is the post-test video. So after 6 weeks of treatment, the patient comfortably can able to lift the limb. So this is the post-test video of my patient. So the results and conclusion, based on the pre-test, post-test data analysis, it was found that application of yearly mid-range functional training is found to improve the upper limb function and the quality of life in stroke survivors. So this is the patent rights which I published in the month of January 2025 for mid-range activation, and then these are all my reference. I thank everyone for this wonderful opportunity, and then I thank INTI International University, and I thank my guide, Professor Dr. Anandan sir, and I thank my dean, Professor Dr. Arunachalam sir, for this wonderful opportunity. Thank you all.